Good morning or good afternoon, ladies and gentlemen, depending upon your time zone. Thank you for coming to the Metagain webinar, Improving Your Patient Collection Processes. I'm Clint Hughes. I'm the VP of Marketing for Metagain. Our presenter today will be Carl Johnson, who is our Senior Vice President of Business Development. He has a couple of decades out there in the field working with doctors' practices just like yours, helping them to obtain their maximum reimbursement. Just a couple of housekeeping issues at the very beginning. If you look over to the right, you'll see an area for questions. Feel free to write your questions in anytime during the webinar, and we will address them then or at the end when we have a break for questions and answers. We will be sending out a recording of this webinar, a copy of the slides, plus one of our most popular ebooks, the 8 most common HIPAA compliance errors. So it's 2 after. So all you early birds get the worm, and I will introduce you now to Carl Johnson, our Senior VP of Business Development. Carl.
Thank you, Clint, for the introduction. And I did want to encourage anybody, if you have questions along the way, we can make this a little more interesting and interactive by just typing your questions in the questions box, and Clint will help me field those. All right, let's jump right into it, Clint. So what we're here to talk about today is getting paid. As most of you are probably feeling right now, the impact of increased financial responsibility on the behalf of patients is really affecting practices. And really over the last couple of years, we've seen big shifts in increases of financial responsibility, and not just on out-of-network policies or hospitalization services or procedures, but just on office visits and first dollar expenses. Really everything except for preventive medicine care now is almost subject to deductible. If we look back historically, you go far enough back, people bartered for medical care, chickens and feed. But by the time you get into health insurance coverage in the 40s and 50s and up until 1960, people were really still paying for most of the health care expenses themselves. In 1960, a stat that I found, 49% of the dollars spent on health care were paid for by the patients. Fast forward to 2002, and we all remember United Healthcare's $10 copays. We're down to 14% of responsibility. Over the last few years, we've seen that go up higher and higher, and would fully expect that we kind of get back to those 1960 rates here within the next few years. So economists have really concluded that the financial incentives for health insurance were kind of messed up over the last few decades. You had physicians who were choosing what services patients got. Patients weren't really able to figure out what they needed to have for themselves. The insurance companies paying for it, and patients receiving the benefit of it. All that led to increased utilization. So look at the little slide or cartoon in the bottom for 2002. Healthcare expenses were rising incredibly rapidly. On into 2015, there was a new trend. And the new trend is healthcare is consumer-directed healthcare. Let's jump to the next slide, Clint. So the idea behind consumer-directed healthcare is that as patients are consumers, if they had more financial responsibility, they would have more control over what was being spent on them, and would reduce utilization. That's really kind of always been the idea behind copays and deductibles, but the theory is that if you put more pressure on patients to watch out what they're spending, that they will actually do so and reduce utilization. We'll see how that plays out over the next few years, but that's the idea here. All right, next slide, Clint. So the trends in consumer-directed healthcare really coming at us from every angle: the government, private insurers, employers, even especially Obamacare, large deductibles. Obamacare, many products are $6,000 plus deductibles. Out-of-pocket payments overall for patients are expected to grow from $250 billion just a couple of years ago to $420 billion, a 68% increase over the last 5 years. And the number of patients with high deductible plans rose in 2014 to nearly 17.5 million, an average growth rate of 12% a year since 2013 and 15% if you go back clear through 2011. The percentage covered by workers with a deductible of over $1,000 rose to 41% in 2014, our last good data. Let's jump to the next slide, Clint. And actually, I would venture to guess that it's considerably higher than that at this point. This graph, the blue bars on the top show employee out-of-pocket expenses, but what's also interesting is the yellow bars show the employee's contribution to their health insurance premium. So not only have the patients paid more out-of-pocket, but they've paid an increasing amount to their employer to cover these health insurance premiums. All right, next slide. So in 2014, 80% of employees had deductibles as compared to 52% in 2006. 41%, this is in 14, had deductibles of $1,000 or more, 20% with $2,000 or more, and I think if we looked into 2016, those numbers are up considerably, and certainly by the end of this decade, there probably won't be very many plans at all, except for a few luxury plans that don't have, $2,000 plus deductibles. And that's on top of that is the cost of the copays and the co-insurances and pharmacy expenses. All right, Clint. So the challenges for our practice is collecting this money. So when we're thinking about it, especially early in the year, and it seems that everybody's deductibles come due the first of the year, that we end up with severe cash flow crunches in our practices. So typical process is people are waiting for the insurance companies to adjudicate claims before they're trying to collect from the patients. And then once they go to start collecting from the patients after the insurance companies have processed claims for January and probably the first half of February, you've got to chase the patients down for that. And statistically, it costs about 2.5 times, 2 to 2.5 times the amount to collect from a patient than it does from an insurance company. We think about insurance companies, as long as you get a good clean claim out and the patient has active insurance, good CPT codes, diagnosis codes, it's going to get paid, pretty often on the first pass. With a patient, you've almost always got to send them at least 1, if not 2 statements, and there's a significant cost to that, typically 60 to 80 cents per patient statement. The thing to remember is that a patient balance becomes less and less valuable over time. So not only is it harder to collect as time goes on, you're much less likely to collect it. So I predict that the value of a patient balance declines by 1 to 2% every day. That goes on. All right, Clint, the next slide. So from this next slide, we'll be able to see, maybe we won't see. One more slide, Clint.
Okay, you were breaking up. Yeah, you were breaking up there a little bit.
So if we look at the value of $1. Okay, yeah, you're breaking up a bit too, so let me know if you can't hear me. So when we look at the value of a patient dollar that's owed to you, at 90 days or less, you should be able to collect about 87% of it. When you get to over 90 days, into the 120-day mark, and up to a year, you're talking about collecting 1/3 of it. Over a year and up to 2 years, 22%, and over 2 years, well, just 3%. All right, next slide, Clint. So really the statistics will show us then that the best time to collect is at the time of service. And that's something that not every practice is used to, but certainly that's been the trend, and everybody is really kind of leaning in that direction. So if we look at collections at the time of service, the bare minimum that you should be doing is collecting the copay at the time of service. Beyond that, I would hope that everybody is collecting the copay, plus any old balances, plus if they have a procedure or a surgery coming up, collecting a payment or prepayment on that. And really the best practice in ideal world, you're collecting, in addition to those items, you're collecting co-insurances and remaining deductibles. That's not so easy to do. We'll talk about how we can do that with some tools. All right, next slide, Clint. So the most important thing to do is to establish a really clear collections policy with your employees, support staff, and patients. So when we look at that, it just shouldn't be a surprise to your employees that we're going to collect this money up front. Shouldn't be a surprise to the patients that we're going to be looking to get paid their portion of financial responsibility. Gone are the days when we can just waive that $10 copay from Aetna and say, don't worry about it, just come back. Let's jump to the next slide. So setting expectations with the staff is important. And really, I think I like to describe it to them like going to the grocery store or the gas station. You wouldn't dream of going to the grocery store and picking up a big ribeye steak and taking it out and say, just send me a bill for that. So why would we expect to do that in a doctor's office? I know we've all talked about this, but it really is important to kind of communicate that to the staff, help them have an understanding of the dynamics. I like to explain to the staff why this is so necessary, to understand that if 50 or 60% of the practice's revenue during the month of January and February and March are going to come from patient responsibilities. If you don't collect that, you're not going to be able to make payroll. It's just that simple. And usually it's the doctors that are ones that are suffering, and the last thing we want is doctors that are unhappy. I teach the staff to expect the payments from the patient, not just to ask nicely, would you mind paying me, but to really be straightforward with patients and say, call them by name, smile, be polite, say thank you, ask if they have any questions, but say something like, charge today is $50. How would you like to pay for that? We take MasterCard or Visa, which is better for you. So you're not giving them an option to say no. You're just giving them 2 yeses to say. Conveying a sense of urgency with the patient. So it's not like, oh, well, if you don't have it, no worries. And I see that a lot in doctors' offices. Staff members really aren't looking to, do anything they feel might be a conflict with the patients, and patients hadn't been used to paying that. But I will tell you, I know sometimes we all get stuck in our own worlds, as I spend a lot of time in different doctors' offices listening to people at the front desk. I do hear more and more from patients, they really are expecting to pay at the time of service. So again, don't make delaying payments, going on a payment plan, an option right away. There may be times when you do need to set up a payment plan for somebody when they just simply cannot pay or they don't have the ability to, and you're going to provide them care anyway. Make sure that that's not just offered up right away. I always like to provide a private place to discuss any financial concerns, and sometimes that's just as simple as having, the office manager's office available so that you don't have somebody talking about, their inability to pay or their need of some assistance right at the front desk where there's people checking in and checking out. All right, let's move on, Clint.
Remember, folks, we are recording this, and we will be sending you a copy of the slides.
Thank you, Clint. All right, so collecting at the time of service. So really there's a lot that kind of goes into this, rather than just not asking for the payment at the time of service, but really making sure you have good information at which to follow up with the patient on collecting, and really that follows up with the insurance as well. But you want to get good, clean insurance information so you can get that paid. You want to verify the patient information when you're making appointments, either in person or over the phone. And I'd like to make sure that you let the patients give you their address rather than you just read off the address, or if you just say, has anything changed? You might say, oh no, nothing's changed, but meanwhile they've moved and changed insurances. Address, phone number, email. Email is becoming and will be becoming increasingly important to capture, as well as current insurance information. And you're going to want to verify that every time that you see one of those patients. So you may not have to have them complete the whole registration form, but you may say, Mr. Johnson, are you still living at, and then pause and let them finish the sentence for you. Again, verifying that address, phone number, email, current insurance information is all good stuff to do, and I like to do it at every visit. It improves your probability of getting paid in a timely way. Now, when a patient has a copay, co-insurance, and deductible, your front desk staff that's working with those patients at check-in, check-out needs to know how to research that, needs to know how to look at the insurance cards, needs to know how to look at Navinet, needs to know how to do eligibility verification through your EMR or practice management system. It's also important for them to have a good grasp of CPT codes and modifiers, and we'll get to why that's important here in a minute. Also, I really recommend being able to identify payer allowables for each procedure. For most practices, for work done in the office, you'll be able to capture 75 or 80% of that in 10 or 15 codes. and 4 or 5 insurance companies. So by just looking at data that's readily available from EOBs, I mean, you could go down to the insurance companies and try to get the contracted rates. If you have enhanced rate contracts, that's a good place to go. Actually, an excellent thing to do. But in absence of that, just look at the EOBs and say, I know Blue Cross pays $78 for a 99213, and that's their allowable rate. It gives you at least a ballpark when you're trying to calculate what somebody's deductible payment should be. So if you're collecting co-pays, I recommend doing that before they go in to see the physician. There may be a question about whether or not it's a preventative medicine visit or a sick visit. Many times somebody comes in for a preventative medicine visit, you wouldn't collect a copay for that, but find out that it converts to a sick visit, so you would need to collect a copay to that. But according to the MGMA, nearly 30% of patients today are leaving the doctor's offices without paying anything at all. And that just creates, you know, an immense expense on the part of those physician practices in order to collect those payments. Calculating an estimate for payments is something that is challenging. There are some software applications that out there that do a pretty nice job of that. Instamed is one that we use a lot. Navicure does it as well. Many of the insurance companies, or many of the EMR companies, are starting to put these functionalities into their systems where you can come up with a pretty good estimate of what the patient's going to owe towards their deductible or co-insurance based on how the insurance carrier has previously adjudicated those claims. It's not always simple. This is certainly something that is maybe better saved for practices doing higher end procedures rather than basic office visits, but something even a pediatric practice could be successful at. So coming up with an estimate of what the patient's responsibility is based on the CPT codes, you obviously can't do that until the physician has seen the patient, and the physician needs to code the chart before the patient leaves if you're going to be able to do this. If you do come up with an estimate, it's good to have that in writing and an initial by them so that they understand what their financial responsibility is likely to be. If you don't do this properly and you're collecting a lot of money at the time of service, collecting for preventive medicine visits you shouldn't be, you're going to end up with a lot of phone calls, unhappy patients, issuing a lot more refunds, and actually sending out a lot of statements to patients for smaller balances if you're off by a little bit. All right, Clint? So I like to keep it simple and on a positive note. Hi, Mr. Jones, your insurance requires a copay of $50 for this visit. How would you like to pay? So really not making it optional, but really making it so that patients understand what the expectation is. Once you've got their credit card in hand and are ready to process that $50 copay, you might also say to them, I see there's a balance on your account of $15 from your last visit. Can I go ahead and add that to your charge? I'll tell you, you're twice as likely to get that payment if you have the credit card in your hand rather than their hand. Just a little trick. All right, next slide, Clint. So you can request payments from patients in multiple ways. We have a lot of contact between patients and the practices. We're setting up appointments, we're making reminders, we're doing clinical callbacks, we're maybe making a collection call to them. But those are all opportunities to follow up on a balance. And sometimes it's just a simple reminder if they need it. In addition to doing it when we're on the phone with them, some practices through their appointment reminder systems are able to send payment reminders via text or email, or if your EMR system has a patient portal, that's an excellent way to do it. All right, next slide, Clint. This is a good one, and this is kind of a bridge between being able to collect those deductibles and co-insurances up front. And that's where I say it's a great idea to get a credit card and keep it on file. Now, when I say putting a credit card on file, I don't mean making a photocopy of the card front and back and putting it in the patient's chart. And I have seen that happen. Or putting it in a file folder in the office manager's desk. You're just making it real easy for somebody to steal all that credit card information and to get you in the newspaper, and nobody wants that. However, there are a number of tools out there, Instamed, as I said, being one, but many others. Many of the EMR systems, NextTech, for example, has a nice credit card processing module now built into it, so do many of the other systems that we use. and you're able to securely store the credit card information on file in a way that nobody at the practice would even know what it was, and nobody at the EMR company or the credit card processing company know what it was. It's just like going to a hotel and putting a credit card on file. So what you'll do is you'll keep a card on file for small payments, and you'll tell the patients, we're not going to charge your card more than $200 or $300 without talking to you about it first. But if somebody has a small, $25 co-insurance from an office visit after they paid their co-payment, then you don't want to have to chase them down for that. You don't have to send a patient statement for such a small amount. So if you have the credit card on file, as soon as that claim is processed, you can charge that. So there's a good way to do this, a bad way to do it. You're presenting it to the patient in a way this makes their life administratively much easier. You're going to do it for small balances. It's good to have a little policy written up to keep that on file when you're taking a copy of or when you're processing that card. But really remember, you want to make sure the patients understand that it's not that you're keeping a photocopy of their card or the number. It's all secure. All right, next one. So as practices are really shifting their focus on more patient payment collections, storing credit card information can really help you. And this is something that probably is one of the best things you could do. Next slide. So when you're using those credit cards on file, it's good if when you're seeing the patient, you can say, we think this bill is going to be, for the service you had today, $300. Your patient responsibility, you have a 20% co-payment, it's going to be $60. That's what we're likely to charge your card for. We won't charge you until the insurance company processes the claim. So you obtain a written consent to charge, up to a financial limit. And then you use a gateway or a clearinghouse to approve and to store that information. And that could be anything, like I said, from Instamed to your own EMR system. I do recommend that we process those payments in a timely manner so that when the insurance company processes a claim, you get an electronic remittance advice back. You have a system in place where you're going in and you're processing those payments right away. So you don't want the patient to get an EOB and say, okay, yeah, I promised I would pay that $60, and then you not charge them for 3 months. And then you go back and charge them, and they're going to call you and say, what's this for? Because I don't remember. Just going to create a lot of headaches for you. I like to notify the patient once you've made that charge to their card, what you've done. Could be done by a phone call. That's cumbersome. But many of the portal systems that are out there have emails or text message options where you can send them information, really a copy of the receipt electronically. Payment plans are something we should talk a little bit about. I recommend that on payment plans, when you're setting those up, obviously you're going to use good judgment. But if it's a relatively small balance, say $500 or less, I try to get the patients to clear that up within 3 months. If it's more than that, I'm still not looking to make it a long-term payment plan, somewhere 5 or 6 months. Again, you've got to use good judgment there. And when you do get in a situation where you've received an overpayment, you want to make a refund before the patient starts asking for it. Now, you may have a policy that if a patient's coming back in, you'll put that on a balance on account, but just have a policy that the patients know what it is. And if you owe them a refund, process the refund. It does mean that you have to look at credit balances on a real regular basis, and that takes some discipline to do. All right, next slide, Clint. So the benefits of having a credit card on file: inform patients, reduced days in accounts receivable, improving the cash flow, elimination or reduce the number of patient statements. You can manage those payments electronically, eliminate bounce checks, eliminate manual refund processes, because you can actually make refunds right on that credit card on file. You can eliminate cash drawers and trying to balance out money at the front desk. You reduce or eliminate the number of times you have to go to the bank to make deposits. Most everybody's using a check scanner for the paper checks they do get. It really speeds up the check-in and check-out process, eliminates the need for paper receipts, and reduces overall collection efforts. All right, next slide. So what do you do when the patient doesn't pay? First, offer the patient to reschedule in a nice way. Our policy is we collect the money at the time of service. If you're unable to do that, let me schedule an appointment for a time when you think you will be able to do that. Sometimes I'll recommend having a service charge or a fee. So if somebody doesn't pay their copay, at the time of the visit, and you should have this written in financial policy, you might charge them $20. I find that just putting the sign up that says you're going to charge them $20 so they don't pay their copay at the time of service gets a lot more people to pay their copay, and you almost never have to charge it. Or you could say something as simple as, I'll hold your chart out till the end of the day. If you come back with your copay, and there's an ATM machine just down the block, we won't charge you this $20 fee. You can arrange for online payments and have some vehicle to check and make sure that they're making those. Again, a lot of those patient portals have that capability. You could send a patient home with a self-addressed stamped envelope, although that's expensive. Call. But you can see that all these things that you're doing after the fact are just a lot more work than getting that payment at the time of service. So if you're offering a payment plan, you want to make sure you train your staff on how to manage those options. Try to get as much as you can up front and work on it from there. But it's really good to have that policy straightened out or set by the physicians in the practice. It is their money and they need to choose how they're going to manage that. All right, Clint, now we can go to the next slide. Improving your patient statements is another thing you could do. It's always an education to look at the patient statements closely and see if you could understand them. I like to make sure they're as clear and simple as they can possibly be, that they're sent in a timely manner. Now, there's a lot of information that goes over in the patient statements. They're never going to be super simple, but you can look at those and see what you can do to improve them. Many times they are really confusing. I always like to include the insurance payments if you've already received them in the patient statements, so the patients understand that their insurance company did pay. You can use demand messages for urgency. Many statement processing entities will allow you to put a message on the statement. I actually also like to use a due date. So something that most people don't even think about in the medical business is say that it's due by a certain day. Give them 2 weeks from the day you send it out to make a payment, and somebody will look at that and say, okay, yeah, I got to pay it by the 15th, and they're much more likely to do that than just leaving it open-ended. For all of our Medicaid clients, we have a direct number that comes to us so we can identify the practices. I do like to have a number that makes it easy for somebody to make a payment by phone if they want to call in. Also, I always like to do a credit card payment option, whether that's filling it out on the statements and mailing it back or an online payment. I really like the online payments, and I think that's really where things are headed, so I really encourage people to have that. All right. Electronic patient statements. If any of you, and I still see it from time to time, are folding and stuffing statements in the office, there is a cheaper and a faster way to do that. Basically, you're transmitting an electronic file just like you would submit claims to a clearinghouse. It's going to print and mail those statements. Usually it's less expensive than doing it yourself, less expensive than the postage sometimes. They also usually include an address correction service or forwarding order service to make sure that the statements are getting where they need to go. And sometimes with those patient statements, you have the option of processing those through email or through a patient portal, and also can be less expensive and faster. All right, Clint. So considering online payments, whether it's a practice portal through your EMR system, and most have it now. Didn't used to have it even a few years ago, but they've all kind of jumped on the bandwagon. The one downside to that is you may have to shift where you're having your credit cards processed, but that is something that can help you get paid faster. It's convenient for the patients. You're going to get paid quicker, and at the end of the day, I think it increases your revenue. So overall then, when it comes to collecting patient money, I like to shorten that collection cycle. And really, if I look at this entire cycle from when you send the initial statement to when you're sending somebody off to a collection agency because they refuse to pay, is keeping that time frame in the 75 days to 90-day range is something that I would strongly encourage. So you're much more likely to have a collection agency get a payment for you if you get to them within 90 days. It's when you give somebody a $50 copayment that's 3 years old, they'll never be able to collect that. So sending an initial statement should be done when the patient balance becomes, when the financial balance becomes the patient's responsibility. Oftentimes, I'll send a second or a third statement, again, depending on what your practice personality and protocol is. You may or may not want to follow up with a patient phone call, depending on the size of the claim, or send, and I always do like to send a dunning letter or a soft collection letter. Once you've gone through that process, sending it to an outside collection agency for review makes a lot of sense. At Medigain, we're processing both statements and those dunning letters to make sure that patients are understanding what their balances are. And then frequently I find that the practice will be successful at making phone calls or at least reviewing the list of accounts that are recommended to go to collections and making one last phone call on them. They may have a personal relationship, and that can certainly help. All right, Clint. So I'm just going to kind of summarize and draw some conclusions here. Consumer-directed healthcare is here to stay, at least for a while. Means you're going to have to collect from the patient. That's going to be more difficult, more time-consuming, and more expensive. It's more important than ever to have an educated staff. The staff needs to feel good about what they're doing. Collecting money from patients is not a bad thing. It's a new dynamic, and if they understand that and they're part of it, they can help you meet your objectives. Collecting copays and deductibles really at the time of service is the time to do it. Anything other than that, you're going to be chasing it down. You're going to be losing a lot of revenue. Next slide.
That's it. Establish the credit policy.
Oh, establish a credit policy. Sorry about that. Really having that credit card policy, those credit cards on file, is something that can go a long ways towards getting you paid in a timely manner. It's something that is becoming more and more common. 3 years ago, you saw very few credit card payment processing systems. Now I think almost every EMR system has one where you can keep a credit card on file securely. All right. Cleaning up your patient statements and shortening your collection cycle, also good kind of housekeeping things to do, along with collecting the money at the time of service. All right. We have any questions? I wanted to open it up. We had lots of questions at the last session, and if anybody has any questions, you can just type them in the box, and we'll go from there.
Yes, Carl. As a matter of fact, we did. One person had a question, kind of a point or a tip on that part where you are trying to collect and you send a letter and then you follow up with a phone call.
Mm-hmm.
Kind of phrasing that might be politically correct in that situation.
Yeah, so if you're calling and the patient has an outstanding balance, I keep it very positive and upbeat. Clint, I see you have an outstanding balance, or a review of your account has shown that there's an outstanding balance of $50 from your office visit. How would we like to take care of that today? So it's not a do you want to take care of it, but it's a how you'd like to take care of it. So that's kind of how I kind of push people to do that.
Yeah. Here's a group that they're out of network with Blue Cross, and Blue Cross sends the doctor's payments to the patient for the patient to then send to the doctor office. When the patient keeps that insurance check, they send them to collections for the full amount. Can we collect this amount up front as well as the patient's part, or just let them keep the checks?
Excellent question. So when we're talking about being out of network means you don't have a contractual relationship with the insurance company. So you are entitled to collect your full fee from the patients. The only caveat to that is it ought to be a fee that's based in some sort of reasonable manner. You shouldn't be charging $50,000 for an office visit. Now, you're welcome to collect that amount of money at the time of service. You're welcome to bill the patient at some future date for it. You're willing to offset your total fees by whatever the insurance company pays, or many times patients or practices are accepting the insurance company's payment as payment in full, and those are all options you have. The rules vary a little bit from state to state on what you can do there, how many attempts you need to make to collect any balances on out-of-network. But I think the bottom line is, yes, you can collect that up front. That is kind of a soul-searching question to say, will patients still come to me if I'm collecting all the money up front, or won't they? And sometimes the answer will be yes, and sometimes the answer will be no. All right, Clint, what else have we got there?
Well, it says, when they're handling the collections in the office, not using an outside service, but after 90 days, when should the collection attempts cease, or when should they write it off? Rule of thumb.
So kind of a rule of thumb, and this is something I see from time to time where a physician especially in a referral-based practice, say you're a urologist or an oncologist, somebody who's getting referrals from other physicians, you don't want to send patients to legal collections. You know, maybe the doctor feels that's part of his mission to the community, whatever the case may be. If you're handling it in-house, by the time you have gone through a statement process of sending statements, 2 statements, or 3 statements, a dunning letter as a last-ditch effort before sending to a legal collection agency, or in this case they're not going, you've made a couple of phone calls. If they haven't really responded at that point, they're never going to respond. So by the time you've made 2 or 3 pieces of correspondence going to the patient and a phone call going to the patient, even if you're just leaving a message, if they don't respond, they're unlikely to respond. And then I would either write that off to bad debt, or better yet, really send it out to a collection agency, because if a patient's not paying you their responsibility, you know, do you really want to have those patients in your practice? And if they're not paying you and it's coming from a referring physician, it's quite possible they're not paying the referring physician either. All right,
okay.
Clint?
And there was one about, is it better to accept credit cards for copay? I guess it really doesn't matter if it's a credit card or cash, but there is a processing fee if you do the credit card, correct?
Right. There's a processing fee for credit cards that can be up to 3% or more. It depends on the type of cards, the credit card processing company, and a little bit based on the individual type of cards. A cashback card, for example, is going to charge you a little more of a fee. So there are some fees that go into that. However, I would say if you had to look overall and say, am I going to be better off by accepting credit cards for these over-the-counter money or patient responsibility versus not, the credit card processing fees are going to be far, far less than the amount of money you're going to have to write off or to send out to a legal collection agency because, you know, you didn't collect at the time of service. So I think you're better off. But again, that's a choice over practice.
Okay. Last session, there was a little back and forth about Medicare and collecting for the deductible, and then their 20% of co-insurance.
Sure. And kind of two questions, yeah. But let me kind of address those. So the first one is, are you responsible to collect that Medicare co-insurance and deductible? And the answer to that is just simply yes. You can never routinely write off co-insurances and deductibles. On rare occasion, if you can really demonstrate financial hardship, you can make an adjustment there, but that needs to be well documented and records kept for that. But you need to make a reasonable attempt to collect it. It doesn't mean you have to collect everyone. If you are billing patients for their co-insurance or co-pays and they don't pay, and you follow the same protocols you're following for the rest of the practice, which is at least some sort of reasonable attempt to collect the money, then you're okay. But if you're just routinely writing them off, that's bad, and you will probably be expelled from Medicare in short order as soon as somebody figures it out. The other question is can you collect on a Medicare deductible at the time of service? And the answer to that is yes, with a caveat. And the caveat is you have to be really careful. More importantly so if you're a specialist, because if you're seeing a Medicare patient in February and you think they still have a deductible, maybe even call Medicare and ask them, and there's still a deductible outstanding. Maybe there's a claim from a primary care physician they saw a week ago that just hasn't gotten processed yet. And so you want to make really sure that that you're not kind of collecting a deductible from a Medicare patient and they've already paid it somewhere else. And maybe they didn't actually pay it somewhere else, but that first physician got their claim in first, and that's who's going to get hit with a deductible. So that's a little tricky.
Right, and that looks like that might have sparked this next question about, she says, am I correct in telling our staff that copays and deductibles cannot legally be written off since they have a contract with the insurance plan? It says sometimes
right.
You pay discount rather than professional courtesy.
Right. So when it comes to collecting co-insurances and deductibles for insurances, it's not illegal not to collect them in most cases. I won't say in all cases, but in most cases it's not. However, it is a violation of your contract with the payer, and you're quite likely to have issues with the payer if you're routinely not going after copayments and deductibles. Remember, the whole purpose of those copayments and deductibles is to reduce utilization, because consumers are now looking at what they're spending. So the insurance companies want the patients to pay these. It's not like they just want to do them a favor and say you don't have to pay. Does that answer that for you, Clint?
Yes, I believe so. And the last one that we have, folks, unless you want to type in some more over there in the question box, is who is responsible for payment in a divorce case for minors? I always make it the responsibility of the parent that brings the child in for care. Is that correct?
Probably is going to be correct, but not necessarily always. Really, the responsible party for a minor is going to be whoever the custodial parent is. So that may or may not be the person who's bringing the child in for care. Quite commonly, joint custody is the order of the day, but not always. So just something to be careful about there. But again, collect the money at the time of service. I would be cautious about having, somebody come in, dad come in with the kid and say, oh, it's mom's responsibility to pay. Just know up front you're never going to see that money.
Okay. Well, right. That about does it for the questions for today, Carl. I'd like to remind everybody that here later on this afternoon or tomorrow morning, you'll be getting an email from Marketing at Medicare, marketing@metagain.com, with a link to where you can view this recorded webinar, get a copy of the slides, and also a copy of that ebook that we promised you, the 8 top HIPAA compliance errors. And so, Carl, I'll leave it to you to wrap up.
All right. Well, I want to thank everybody for joining me, and good luck collecting those patient responsibilities. There's a lot of them out there this year to collect. Thanks, everybody, for joining us, and hope you have a great afternoon. Thank you.
Thank you all. Bye-bye.